The physician services at the referring site can be an issue. You've got an emergency room physician, typically in a busy emergency room, and there can be perceived sense of having to hang around watching television for a while when they want to get on with other patients. In reality, it's possible to run this whole show. I'm sure Phil would have a similar experience, but it's possible to run the show from the consulting end with just a nurse at the other end. In fact, I've actually utilized the patient's family to help me examine the patient's visual fields when the nurse had to head off to do something quickly. But a quick handover from the emergency room physician and some reassurance to the staff that they may not have to stand around or sit around while you're doing your exam and making your decisions, and then get them back when you've decided what you're going to do. Like all these things, if you only do it once a year, then there's enough technological hurdles that it's just not going to work well for you. So you've got to have a sufficient volume to make it worthwhile. And you can't be so far out in the boonies that your bits and bytes are traveling by pack horse. You know, you've got to have fairly good telecommunication lines. So next slide. Yeah, that would. The service requirements at the referring site include a secure network for this video. I've never quite understood this because I think hacking into the hospital's electronic health record system would be far more information than one video stream of somebody's face. But at any rate, there are security issues surrounding the network carrying the video. Diagnostic imaging, as I've mentioned, needs to be sorted out, including making that accessible to other physicians and such. And surrounding all of this, the inevitable privacy impact assessment, which will draw a lot of people's time, filling out innumerable forms that are hard to understand, but have to be done. Keeping an operation like this going, as I've said, you don't have much warning. These patients suddenly turn up and it's sort of 0 to 60 in 3 seconds. And if things don't work, then you need to have to turn to somebody who can give you the technical support for when you're not getting an image or sound is not right or you can't bring up the other site. Fee codes for doing this have been sorted out, and we don't have to do that again, so that's just historical at this point. Some mechanism of recording your consultation visit and then sending that to the referring site has to be sorted out. And the whole notion of clinical readiness, you know, are you ready to be a stroke hospital, needs to be really sorted out, and that's probably the most important part of the piece. And next slide. So over the course of since July 2009 through up till now, we've been measuring what has happened in these two pilot sites, which, as I've mentioned as well, are occupying a different part of the spectrum. So it's good. We're testing different parts of how this has to happen. And I think the Vancouver model really more so testing how you would do this provincially, because they've had to cross all of those hurdles that you would have to cross for crossing different healthcare regions and new referral routes, etc. And so we've gathered together some of that data. Let's have the next slide. And the Vancouver Island experience, we got off to a good start. In fact, I think we did our first patient the day before it was supposed to open. But that was largely because we were already running in this fashion. We already had these doctors phoning us, and so we would say, well, why don't you switch on the video? And although that works for a good quick startup, it doesn't really augur well for mounting numbers over time. So our numbers have been pretty well static. And as well, the data here is going to be different than you're going to see for Vancouver Coastal, because if we look, for example, at a site in Alberta like Edmonton and look at their progress over time, they show data about how many patients they've seen, or sorry, how many patients they've managed using the telephone-based system, which is the old-fashioned way of doing it. So they already had a system set up with PACS and the telephone system. And then over time, with telestroke's emergence, you'd see less and less patients being done by phone and more people being done by video. And that's been the evolution in the Alberta model. And to some degree, we're seeing that here, although in some respects, we've had a bit of a reversal. So over the course of time, we've been seeing we've had 27 cases during that 9-month period there, around sort of 3 to 5 a month, some low periods where we weren't doing much, and some higher ones seeing 5 a month. And of that total 27, 10 were, I haven't got the exact number, but about half of them were done with a video link and half were done with a phone link. And TPA was given in 11 cases.